Oncology in Hospital Kuala Lumpur. So the title of my topic, I just would like to share just my limited knowledge on oncology dietetic. This is closing the gap in nutrition care of oncology patient. So this is the most common cancer in Malaysia based on this Malaysia National Cancer Registry Report 2012 to 2016. So it seems that the breast cancer and colorectal is still the dominant of the most cancers in Malaysia, followed by trachea, bronchus, lung, lymphoma, and nasopharynx. And cancer has been found the fourth most common cause of death in Malaysia based on MyScan 2018. So the prevalence of malnutrition in different types of cancer, so patients with gastrointestinal tract, head and neck, liver and lung cancer are at risk for malnutrition. So based on study by Stratton et al. 2013, pancreas, approximately the prevalence is up to 80 to 85%. So if let's say patient with cancer of pancreas, you need to focus more because there is a risk of malnutrition. And then followed by esophagus, stomach and head and neck. So the prevalence of malnutrition worldwide is estimated around 20 to 70%. It's highly prevalent in adult and advanced stages. And it also estimated that cancer-related cachexia occurs up to 20% of cancer death. And then study by Planners et al. 2016 among cancer patients in European hospital is estimated around only 30 to 60%. Only half of the patient actually receive oral nutritional supplement or nutritional support. And cancer patient with cancer are high risk of malnutrition because of the disease and the treatment that threaten their nutritional status. And when the side effect of cancer treatment affect the normal eating, changes need to be done to help the patient to get the nutrients needed. So treatment for cancer, basically surgery, chemotherapy, radiotherapy or targeted therapy. So the malnutrition also likely to worsen during specific cancer treatment, like I mentioned before, when early and inappropriate nutrition intervention is not properly indicated. So subsequently it can negatively impact patient ability to complete treatment and interfere the quality of life. So basically around 75% of patients actually reported fatigue, weak, lethargic since beginning of the treatment and experience more diet-related issues later on. And about half of them has decreased appetite. Memang kurang selera makan. Kalau tanya, pakcik boleh makan ke? Kadang kata boleh. Makan apa? Bubur. Berapa banyak? 2 hingga 3 sudu. So sebenarnya tak cukup yang dia makan. Yeah? And then some of them also complain of very thirst, dahaga. Tapi tak siapa yang boleh bantu because actually they need the assisted feeding. And this patient also reported significantly increased taste sensitivity. Dulu kita ingatkan dia orang suka benda-benda yang macam manis, but then based on the study done, actually they are more sensitive to salty and bitter taste. Suka yang macam masin-masin, pahit-pahit, and they also have this altered smell. And then this patient also reported higher level of weight loss, lower energy intake, and subsequently can worsen the quality of life. Therefore, dietary intervention such as dietary counseling, flavor enhancement, oral nutritional supplement, or tube feeding has been found to lessen the weight loss, improve the health and nutritional status of this cancer patient. So what actually is a quality nutrition care? We want to close the gap. We want to understand the patient more. Bukannya dengan sehala saja. It's two-way. First is the content of care. It should be based on evidence-based, scientific principle, protocols, guideline, parenteral or enteral nutrition. Then process of care, nutrition care process. Tak boleh terus jumpa patient cancer, terus nak intervene without you take what is the nutrition diagnosis, what is the nutrition assessment, and subsequently with this model, it helps to improve the quality and healthcare status of this patient. So this is the American Dietetic Association nutrition care model that normally we as dietitian we practice. We will screen, we will assess, we will do the nutrition diagnosis, intervention, and subsequently the monitoring and evaluation. So based on evidence-based guideline, we do have the MMT for cancer, we do have the SOP for cancer patient, and there's a few journals or recommendation, ASPEN, ISPEN, okay, that available, that help us to sort of to intervene this kind of patient. So actually, how you want to put this theory into practices? So it should be based on this current best evidence, expert opinion. So it helps us to understand the patient, to have the most appropriate and effective management of nutritional and metabolic problems in patient. So nutrition screening. So actually, nutrition screening is unnecessary if the patient referred by dietitian by other methods, such as direct referral from physician, medical officer, oncologist, then you can just proceed to nutrition assessment. So it's very crucial to detect the nutritional disturbance and subsequently to evaluate the nutrition intake. Kadang-kadang awal-awal boleh makan, after treatment, pre-treatment, 2-3 hari, bau-bau sekitaran, dan pemakanan tu ataupun oral intake subsequently will reduce. So this is the flow chart that I mentioned it earlier. Nutrition screening, it has to be timely, 24 hours. Bukan dah 2-3 hari baru kita nak screen. It should be within 24 hours. So basically what we use is malnutrition screening tool. It's very quick. It is validated for cancer patient, for both outpatient and inpatient. It is the pricing is actually based on intake, appetite, weight changes, and there is a BMI also. If the BMI is less than 18.5, actually it's a direct referral to dietitian. So this is the question. Basically, if the answer is, have you lost weight recently without trying? If unsure one, there's a risk of malnutrition. Okay. So and then it helps us as dietitian what needs to be done. For example, patient moderate nutritional risk, MST is 2 score. Okay, so recommend high calorie, high protein diet, small frequent meal, or let's say if patient unable to eat adequately, you can supplement it with oral nutritional supplement. If let's say the plan also unable to meet the recommended, we can suggest for rice tube feeding. So this is the HKL nutrition screening. Previously, yes, we done this nutrition screening, but then the referral is a lot. So now we are focusing only the direct referral from this oncology. So this assessment, routine assessment, is very important to assess the nutrition intake, especially nutrition impact symptom. Okay. So this is for nutrition assessment. We have this tool also validated, the PGSTA. This one is actually answered by patient. The question is weight, and any other symptom, your food intake, either your food intake is unchanged, decline, and then your physical capability. So this one is assessment actually can be done by the physician, the dietitian, or the nurses, but this one need to be well trained, okay, because it's because of the score. Then after the score, we can categorize the patient. Is it patient is malnourished, moderately malnourished, or severely malnourished? If severely malnourished is stage 3. So the aim of actually the PGSTA actually to maintain the score or to reduce the score. And then if let's say patient has score 4 to 8, patient need intervention by dietitian. Monitor weight. Monitor weight for oncology patient is very important. Need to monitor at baseline and weekly. Some of my patients sometimes we monitor them daily. Sebab kita kadang-kadang tu kita dah intervene and then patient still the weight is not catching up. Dia tak naik-naik berat badan. And the goal is, actually is less than 5% of weight loss in a month or 10% within 6 months. This is very important if let's say patient took combined therapy, the CCRT, chemo plus the radiation. Okay, and then actually the weight maintenance or prevention of further weight loss is more appropriate than restoring the pre-illness. Pre-illness setahun lepas 70, masuk dekat ward sekarang 50, tapi nak aim yang 70. Sometimes tak, kita just kalau boleh kita tak nak untuk elakkan lagi penurunan berat badan. So BMI yang weight loss, what is the definition of inadequacy of food intake? Cannot eat for more than 1 week, or the estimated energy intake is less than 60% requirement for more than 1 or 2 weeks. And then partial reduction in food intake also result in large calorie deficit over time. Semalam makan, kadang tak makan, and subsequently akan ada this calorie or protein gap. And both, kalau let's say higher BMI and there's a low percentage of weight loss, actually it's better survival. Okay, so normally based on this Aspen guideline 2017 for cancer patient, the ideal BMI actually is between 25 to 28, okay, and the weight loss actually less than 2.5%. So this is the systemic review meta-analysis done by a few researchers. So weight stable patient with BMI more than 25 has the longest survival, while the percentage of weight loss, the high percentage of weight loss associated with lower categories of BMI were related to shortest survival. So sometimes how to tell your plan is working? If let's say patient has high lean body mass, low body fat, actually is better. But based on weight, sometimes we are unable to show lean body mass ke body fat. Okay, that is, sometimes kita jugalah, kita rasa macam berat tak naik-naik, tapi rasa macam nampak macam berisi sikit kan. But this is only just a reference or as a guideline. And currently there's a machine, but the BIE not suitable for body composition measurement in individual with patient with cancer ataxia. Dia akan dia bacaan ataupun dia punya result tu tak begitu tepat lah. Okay. Then pharmaconutrients. Sometimes sekarang ni banyak produk-produk and produk and dia ada add in a few components, okay. But so far there is insufficient consistent clinical data to support this pharmaconutrient. But the most importantly is adequate protein and calorie intake. So monitor biochem level. Kena monitor, tak boleh tengok makan berapa tapi tak tengok albumin, C-reactive protein, because kadang-kadang itu menunjukkan patient punya inflammation status. Kalau katakan sometimes albumin very low, mungkin patient ada increase of either high inflammation. Mungkin kita push protein sampai 200 ke 150 ke, albumin pun tak naik. Ataupun patient ada edema, ascites, benda tu pun akan membuatkan suppress of albumin. So sometimes tengok kadang referral albumin low, okay, tapi kita kena tengok apa punca albumin tu rendah. Okay, to monitor clinical parameters, actually there is no single parameters to tell us about nutrition status, but the combination. We need to see the location of the tumor. There's a greater nutritional risk if it's in digestive tract system, okay, and then greater risk if patient already on chemo, radio, or on the combination of therapy. The current situation, we need to detect single signs of nutritional risk for favor of weight loss, and then the nutrition impact symptom, nausea, vomiting, diarrhea, constipation that interfere the access to the food. So clinical, tengok demam tak demam, any GI symptoms, or patient on medication or anti-drugs treatment. Monitor dietary intake, appetite, fluid intake, or any fluid. Sometimes kalau susah patient, kadang kita minta appetite, inadequate diet indication. Patient sebenarnya tak boleh makan, tak boleh telan, tapi dok order normal diet. Actually patient need to order, let's say, minced diet, soft diet, and something like that. Okay. based on insufficient meals. Sometimes kadang patient tak ada poor family support, tak ada siapa nak monitor. So benda-benda macam tu pun boleh menyebabkan patient punya oral intake akan menurun. Detect difficulty in self-feeding and medication or treatment that related with nutrition. So to detect the nutritional risk is not solely depend on dietitian, but it's a teamwork: physician, dietitian, nurse, and pharmacist. So to monitor deep symptom, nausea, vomiting, loss of appetite, mouth sore, diarrhea, and then neutropenic, weight loss. Okay? Sometimes bau kita pun menyebabkan diorang terbau semacam dan tak boleh nak makan lepas tu. Okay? Itu pun most common among cancer patient. So untuk chemotherapy and related nutrition impact symptom, sama lebih kurang apa yang dimention. Cuma patient on hormonal agent, sometimes patient akan experience weight gain or fluid retention. For radiotherapy, radiotherapy ni memang antara, let's say patient on radiotherapy, bukan kata kita fokus semua, tapi mereka banyak nutrition impact symptom pada mereka punya cancer site mana yang kita buat radiation. Okay, basically lebih kurang sama. Nausea, cuma dekat, kalau kata kat batin atas memang dysphagia, mucositis, dry mouth, sore throat, sometimes tak gagal betul. Okay, sampai kita akan talk dengan pharmacist. Loss of appetite, alteration in taste and smell, most commonly only apa yang saya nak highlight untuk gynecology cancer, biasa mereka ada early satiety. So kalau nak push volume yang terlalu banyak, memang benda tu maksud kita concern. Bila kita concern, kita jumpa dengan orang, kita cakap, dia rasa kita ni macam faham dia, tak ada kita nak push dia saja. So untuk yang gynecology, early satiety, cramp, bloating, itu memang the most common nutrition impact symptom. And then let's say for brain tumor, nak tanya diet recall banyak-banyak, sometimes tak berapa betul juga. So it depends. So kena lihat juga kes tu. Tanya dengan kita, dia kata boleh makan, tak boleh makan, sebab kadang dia lupa, lupa, dia tak boleh recall pun. So di HKL, basically this one yang kita encounter, patient yang buat radiation dekat sini, memang sebelum buat radiation, dia akan measure pakai mask. So 70 kg. So kalau kita tak bagi diorang, tak advice, tak counselling, kadang-kadang muka diorang kecil. Bila kecil, dia akan interfere. Mask tu tak properly fit, and then dia akan affect dia punya treatment outcomes. Okay? Ada juga yang kadang mask tu terlalu ketat. So patient referred to dietitian, lepas tu kita cakap sebenarnya patient yang restrict dia punya food intake sebab dia tak mampu nak tahan bila pakai mask, nak kecilkan badan dia. So benda-benda macam tu lah yang kadang kita kena advice dan kita akan discuss lah dengan team. So teamwork, good communication skill is very important. Kita jangan work in silo. Kadang kita buat regime kan sendiri as a dietitian, but kita kena inform dengan doktor, doktor patient ni macam ni, ni macam ni, ni macam ni. So at least the holistic care is there. Okay? So in HKL we have this MDT team daripada Sungai Buloh akan datang. Kita akan discuss tentang case, apa GI cases and apa yang akan dibuat, akan datang. So kadang-kadang mereka duduk dekat HKL just for 5 days, for chemo, for 3 days macam tu. So at least kita akan optimize. This one is really towards the quality of care for oncology patient, and then kita tengok juga nutrition impact symptom apa yang mereka ada dan future plans and management. So in terms of nutrition management, actually we want to conserve or restore nutritional balance, minimize any food related discomfort, and then high calorie and high protein to actually promote the wound healing, and then to increase the body, to increase the immunity, to avoid any further weight loss, and subsequently for better quality of life. So walaupun pre-cancer treatment, pre-surgery, or patient ongoing the treatment, actually we want to improve their nutritional status. Okay. So for the energy intake, this is only rule of thumb, 25 to 30 kcal per kg body weight. And then basically, if let's say we want to say about this energy, we go standard actually indirect calorimetry. So far rasa tak ada kot. It's very expensive. And then protein minimum 1 gram, so it's a high protein diet, up to 1.5 or can be up to 2.0 based on clinical judgment. Sebab sometimes cancer patient bukan cancer saja, dia ada underlying disease. And then choice for energy substrate in weight losing cancer patient with insulin resistant to increase the ratio from the fat than from the carbohydrate. This one to increase the energy density and to reduce the glycemic load. For RNI, for vitamins or mineral equal to basic recommendation and discourage the use of high dose of micronutrient. Okay? For micronutrient requirements, there's no specific guideline. However, when inadequate intake or increased losses of micronutrient are suspected, a multivitamin or mineral supplement may be appropriate. Okay? For omega-3 fatty acid to improve appetite and body weight with advanced cancer undergoing chemo and at risk of weight loss, it can be used. Okay? It can be used. It helps. But it depends. Kalau tak ambil cukup juga, walaupun ada this component tak membantu. So the energy and protein intake should be adequate. So the requirement based on this MNT guideline is 2 gram EPA per day. This is only the equivalence if let's say you want to convert it into the fish oil or the capsule or the oral nutrition supplement. Okay, so clinical judgment must be used to determine what level of nutrition care should be based on this estimate. Okay, and choices of nutritional therapy, oral nutritional supplement, enteral or parenteral nutrition. So nutrition therapy in cancer patients who are malnourished or at risk of malnutrition has been shown to improve body weight and energy intake. So in patients undergoing adjuvant radiotherapy, there is good evidence that nutritional support improve intake, weight and some quality of life. But in patients undergoing chemo, results are less conclusive. This is the several ways that I mentioned it earlier. Then the efficacy of nutrition intake. So to increase the oral intake in cancer patient who are unable, advise on high calorie, high protein diet. Then you monitor the nutrition impact symptoms. Then offering the oral nutritional supplement. So based on this guideline, dietary intervention with both dietary advice and ONS had the greatest effect. And artificial nutrition, it can be given, let's say patient is unable to eat more than 1 week, or the energy requirement, and energy intake is actually half of the requirement. So if let's say the oral nutritional is inadequate, then proceed with enteral nutrition. If let's say the enteral nutrition also insufficient, then or unable due to any circumstances, then for parenteral nutrition. As a general rule, the risk for parenteral nutrition are regarded to weight is benefit, especially for patients with prognosis less than 2 months. Okay. And then for radiotherapy, especially at head and neck, thorax or GIT, adequate nutritional intake is very important. Okay. Tak boleh makan, proceed pada OMS. Then let's see kalau katakan because of mucositis, tak boleh nak makan, kita duk push pun, pakcik minum dah 6 kali, 3 kali, 8 scoop, 10 scoop, tak boleh juga. And because of his maybe grade 3 mucositis or grade 2 or maybe NG or PEG might be suitable. And then to screen and manage dysphagia because to maintain the swallowing function and to educate patient on how to maintain the swallowing function, let's say the patient on enteral nutrition. For the added pharmaconutrient, glutamine, probiotic, and then this one is actually insufficient consistent clinical data, and parenteral nutrition is not recommended as general treatment. Okay, in radiotherapy, but only if adequate. If let's say the guts functioning, kita guna juga. Okay, walaupun sikit. If adequate oral or enteral nutrition until severe absorption, then it's okay. Alright. For medical oncology, for chemotherapy, also the same thing. Based on this guideline, maintain adequate nutritional intake If oral intake is first, that is the first line. Then ONS, then you can supplement with enteral. If not sufficient or impossible, then only proceed to parenteral nutrition. For glutamine, for patient with this drug treatment also, there's insufficient consistent clinical data. For patient with undergoing stem cell transplant, high dose chemotherapy and stem cell transplant, so you need to ensure also adequate nutritional intake. Okay, if oral intake is inadequate, EN is preferred than EN, unless if there is severe mucositis, intractable vomiting, persistent vomiting, severe absorption, very severe diarrhea, or graft versus host disease, then maybe EN is the choice of therapy. Then for the glutamine also, for this patient with undergoing stem cell transplant, also insufficient clinical data. Nutrition counselling, the first line memang kena counselling. Sebab kadang bila kita counselling, suara kita pun kuat. Pakcik yang bed, kita counselling bed 8, let's say untuk oral nutrition supplement. So bed 9 yang makan elok, apa elok pun nak juga that product yang kita tengah nak suggestkan kepada pakcik. But the first line is actually this oral intake, our food. Okay, and then emphasize on high calorie, high protein diet. And then if let's say patient are able to take oral nutrition supplement, and there is also the argument of feed the tumor, are not supported by evidence related to clinical outcome and should not be used to refuse, diminish or stop feeding. Ada patient yang kata, oh makcik tak buat treatment, makcik tak nak makan, so nanti makcik punya tu lagi besar. We do encounter this sort of question, problem that the patient, tapi kita convince by the patient, persuade the patient, so far okay, patient agree untuk ambil supaya cukup nutrient dan cukup kalori dan protein. So protein, focus on good fats, carbohydrates. Okay, tips kena balance, tak boleh. Kadang-kadang patient suka makan bubur kosong saja. Telur yang kita bagi tak nak ambil, ikan tak nak ambil, ayam yang tak ada hormon saja, tak ada suntikan apa semua, tapi dia kena ambil a good carbohydrate, protein, fat, semua kena cukup. Okay, small frequent meals. Kalau tak boleh makan banyak sangat, ambil sikit-sikit tapi kerap. Then kena ada variety. Pinggan tu kena berwarna sikit. That is normally we educate patient lah. Stay hydrated. So air kena cukup. Kadang-kadang tak cukup tu yang kering. Dia kering nak makan pun susah. So lagi-lagi on treatment, mulut pecah. So kita nak minta dia minum pun kadang kita risau. So kadang kita ambil, tak apalah cik, ambil lah sick feeding, ambil sikit-sikit. At least ada daripada tak ada. Okay, boost up calorie and protein, especially bila patient nak discharge lah. Kita boleh contohnya, tak ada kita suruh minum let's say antara produk tu saja, kita buat sebagai milkshake, smoothies. So ramai cakap, oh boleh makan peanut butter. Macam diorang confused lah. Kadang-kadang mungkin terlalu banyak sangat food meal, food taboo. So modified consistency diet also is very important untuk nurses untuk nak order diet soft ke, mince ke. Selalu kita tahu high protein saja, tapi kita tak fokus on this consistency. Operation actually required blenderized diet. Okay, for low bacteria diet, actually there is insufficient consistent clinical data to recommend this diet for more than 30 days after allogenic transplant. Allogenic transplant maksud dia ambil daripada orang yang bukan daripada keluarga dia lah. The use and effective of this neutropenic diet is not scientifically proven. However, food safety education, food hygiene, and high-risk food restriction are needed when handling this immunosuppressive patient. Okay, fats diet so far do not use dietary provision that restrict energy intake in patient with or at risk of malnutrition. Actually, our target is adequate energy and protein consumption. Okay, so this oral nutrition supplement, this is the product that available that normally yang kami guna. Tapi dia bergantung juga pada hospital. Tak semua hospital, even HKL, we don't have these all products. Okay. So this is for glycemic targeted formula. Okay, this is for fluid restriction or patient with electrolyte restriction formula. This one is this immunonutrition formula. So immunonutrition, arginine, omega-3, nucleotides in upper GI cancer patient undergoing surgical resection in the context of traditional pre-operative care, it is recommended. Okay, but need to monitor because dia ada certain sometimes kita tak bekalkan kepada patient. Okay, so managing nutrition impact symptom. So if let's say patient is at risk for developing nutrition related side effect from treatment, dietitians should see the patient within 1 week of the treatment. Jangan tunggu lama-lama. Soalnya radiotherapy 5 to 10 days, orang dah rasa awal boleh makan, 5 to 10 days dah tak boleh makan dah. Tapi kalau ditunggu sampai week 3 macam tu, kadang-kadang patient weight loss pun dah banyak, existing weight loss. Okay, so loss of appetite, unwanted weight loss, this is only just basic. Saya tunjuk gambar-gambar bagi tak benda menarik kan. So this is the commonly nutritional suggestion, but anything is very individualized for patient. Small frequent meal, consume patient favorite food, don't drink with meals. Tak nak bagi dia terlalu, nanti dia cepat kenyang. Dia tak nak tu, dia tak nak minum pula. Dia dah kenyang lah. Okay, sebab dia berlapik-lapik minum. So it depends. Ada yang kita perlu advance macam tu, ada tak perlu. Okay, proper meal time. Daripada dimakan roti kosong je, so dia sapu lah margarin ke apa. So at least kita boleh boost up dia punya calorie. And then OMS, let's say makan tak cukup, nausea, vomiting, small frequent meal, kunyah-kunyah biscuit kering. Okay, don't drink liquid on empty stomach, dia akan rasa lagi mual. Okay, jangan makan terus nak baring. Ramai patient macam tu, makan minum nak baring. Okay, dia akan rasa lagi mual, rasa lagi nak muntah. Dan bau makanan yang kuat, kadang bila buka tray pun benda-benda macam tu boleh menyebabkan dia orang akan rasa tak lalu nak makan. Okay, dan avoid high fat diet. Okay, it depends, individualized. So untuk taste changes and the strategies, sometimes kita guna plastik ke, kalau dia terlalu tak boleh sangat untuk yang mental taste kan, kadang jadi mentalic taste. Hygiene, oral hygiene paling penting. Kadang-kadang kita duk kasih macam counselling ni, tapi sebenarnya tak masuk gigi. Kalau masuk gigi nak makan pun, nak telan pun rasa tak sedap, tak lalu, benda-benda macam tu. Okay, marinate, kalau bila patient balik nanti kunyah-kunyah, tapi hati-hatilah kalau yang tua-tua tu tak boleh kita cakap pakcik makanlah chewing gum, takut tersekat ke apa kan. So benda-benda ni it depends, very individualized. So in small frequent meal. Dehydration, air kena minum cukup. Okay, kadang-kadang memang kebanyakan patient pun mesti on IV drip juga kalau untuk treatment. Okay, dry mouth, ini yang memang selalu kering, so memang kena minum air cukup. Dan food consistency, kalau kering, kalau kata dia nak juga makan benda yang keras, benda tu akan lagi lagi membahayakan lah, lagi akan menyebabkan ketaksesaan. So kita offer je moist, bagi je, sebab sometimes dalam fikiran dia tak ada fikir. Macam kita rasa patutnya kering, of course automatically kita akan fikir soft diet, tapi patient sekarang dia tak boleh fikir. Yeah? So dan avoid any spicy or citrus food. Mucositis, ni oral mucositis, dia occurs up to half of the patient receiving chemotherapy. So dia usually begins 5 to 10 days following the initiation of chemotherapy, and it lasts about 1 or 2 weeks. It depends on patient. So bila macam ni, improper food selection can decrease the food intake and subsequently akan lead to weight reduction. Normally, if let's say patient in grade 2 mucositis pun, kita discuss dengan doktor, dengan oncologist to insert rice tube, just supplemental. Ini boleh jalan, ini untuk supplementkan. Kalau tidak, takut weight loss akan banyak. So mucositis sama juga soft diet, gargle, itu penting. Dan makanan, kalau dia nak makan nasi juga, kita kena lembabkan nasi tu, kena ajar dia. Sometimes kicap pun takut makan. Constipation, adequate fluid intake, adequate fiber intake. Kadang-kadang boleh ambil lah, memang boleh cuba minuman yang macam panas, prune ke, boleh stimulate bowel movement. Tapi sometimes doktor pun memang akan prescribe medication juga untuk patient. Untuk diarrhea sama juga. Kita kena tengok apa dia punya cause, apa diarrhea. Is it due to the side effect of the treatment ataupun dia punya cancer itself. So benda tu kita kena tengok. Bukan dia basically semua benda-benda ni kita kena avoid, because at the end of the day is patient quality of life and energy and body intake. But basically is this the general guideline, macam soluble fiber. Okay, avoid dairy products. It depends if only patient are lactose intolerant. But our product available basically is lactose free formula. Okay, for just forming foods should be avoided first if necessary. Yang boleh kita lepas tu reintroduce later. Then kena minum air. Drink at least 1 cup of water after each diarrhea tu. Sebab ORS tu sometimes patient tak berapa nak comply sangat. Then the transition of feeding, resuming oral feeding often requires deep approach. Tak boleh patient boleh makan satu sudu dah off dah semua. Okay, so if the patient has dysphagia, kita refer kepada speech language pathologist to do the swallowing test to verify safe ke tak nak makan. Okay, if the patient can eat safely, counts the calorie to quantify the oral intake cukup ke tak sebenarnya. Okay, then oral nutrition supplement can be used to make up any deficit. Okay, once patient are able to consume at least 50% of needs orally, untuk feeding boleh decrease slowly, bukan off terus. Lepas tu kita nak kena catch up dia punya kalori pula. Okay, nocturnal feeding, kalau ada tube malam-malam kita feed dia boleh juga. Okay, to promote appetite, so siang-siang dia makan. And the tube can be discontinued when the patient is meeting 75% of nutrition needs orally. Transition to home, very important. Apa yang kita nampak kadang-kadang patient the compliance dekat rumah, dekat hospital, kita supply this oral nutrition supplementation. Dia balik rumah, kadang-kadang kalau due to financial constraint apa semua, dia tak comply, dia tak ikut. Masuk balik weight loss, kerana it's not due of kita punya plan ke apa ke, tak tepat, tapi kadang-kadang patient punya compliance. Okay, so kena enforce them, kena bagi tahu dekat caregiver apa jenis subsequently kalau tak comply with this feeding regime. Discharge plan is very important. Kalau patient tak mampu, kali kita boleh refer ke Jabatan Kebajikan Sosial ke, kepada makna, and family support is very important. Palliative care still need to routinely screen patient if found any risk of nutrition risk, and then still kita kena let's say to treat the nutrient impact symptom or any metabolic derangement. To offer and implement nutrition intervention in patients with advanced cancer only after considering this the prognosis of this malignant disease, the expect benefit on quality of life, the potentially survival, and the burden associated with nutritional care. In HKL memang kita work closely with the palliative team. Palliative care was defined as comfort care focusing on quality of life. Enteral nutrition may still be provided as supportive measure, providing nourishment, fluid, and electrolyte. So in dying patient, the treatment will be based on comfort. Artificial hydration, nutrition are unlikely to provide any benefits. Sometimes if relative nak juga, kadang-kadang after discussion kita proceed juga. Tapi tak adalah kita energy intake tu macam patient masih CRT ke apa jadi kita bagi. However, in acute confusional state, to use a short and limited hydration to rule out hydration as precipitating cause. So nutrition support option actually based on comfort food. Okay, kat mana dia? Tapi actually if the type is functioning, kita guna juga, then kita supplementkan. For cancer survival, to maintain healthy BMI is very important, and engage in physical activity, but this one based on patient condition, patient preference. Okay, and then this one needs for further reading. This is only the basic guidelines saja untuk, maksudnya untuk cancer survival, still we need to maintain the healthy BMI. So all cancer patients should be screened regularly. And in all patients, with exception of any care of life, energy and substrate requirement should be met by offering in stepwise manner nutritional intervention from counselling to anti-nutrition, because this cancer patient tak makan cukup, they ada risk of refeeding syndrome. So kita kena monitor juga. However, benefits and risk of nutritional intervention have to be balanced with special consideration in patients with advanced disease. Nutrition management should be based on evidence-based current guideline, and quality control process should be established at each institution involved in treating cancer patients. So providing high quality nutrition care means doing the right thing at the right time, in the right way, for the right person, and achieving the best possible result. So in conclusion, early nutrition intervention is very, very important. Okay, high calorie and high protein diet to meet the requirement. Okay, need to monitor, and at the end of it, good teamwork, good communication skill is also very important. Okay, with that, thank you.